Well, thank you first and foremost for inviting me to give this lecture, opening your conference for psychological wellbeing practitioners on low intensity CBT. So what I'm hoping to achieve in this presentation is give you an introduction to the role of psychological wellbeing practitioner and also give you an oversight and understanding about low intensity cognitive behaviour therapy. My name is Professor Pränd. I'm from our CEDA, Clinical Education Development Research Group at the University of Exeter, and we're one of the leading providers of training, of research and service development under the Improving Access to Psychological Therapies programme, which is taking its mark across the world. And I'm aware now we have interest from Israel in Step 2 psychological therapies, which is great. So I was very flattered to hear and receive the invitation to give this presentation today. So this is going to serve as an introduction to low intensity CBT and the role of psychological wellbeing practitioner, which is fundamental to low intensity CBT and the way it's delivered in England. First of all, why do we need to think about revising the way we deliver psychological therapies and developing a new psychological therapy role, that of the psychological wellbeing practitioner? Well, if we go back 10 years before the Improving Access to Psychological Therapies programme came along in England, mental health was characterised by excessive waiting lists, an excessive amount of time to gain access to a evidence-based psychological therapy. In some areas of England, this was over 12 months. We had the treatment gap, the difference between people who with a recognised mental health difficulty and the number of people who were receiving an evidence-based intervention for that mental health difficulty. And that exceeded 50%. 50% of people who were recognised as needing treatment weren't receiving it. Totally unacceptable. There was a lack of choice also. If people were able to receive psychological therapies, there was a lack of choice of available psychological therapies. So it's not empowering patients to make choice. There was no choice. A big issue was to meet this demand for psychological therapies. This, under the old system of mental health and its delivery, it was hugely expensive. You had a group of very highly experienced psychological therapists, but a small number of those. And those were not able to meet the demands placed upon them. So we had to think of a different way of doing things. In England, this difference came about with the Improving Access to Psychological Therapies programme, which is immensely successful and is triggering a lot of worldwide interest. And within CEDA, we're currently working in Hong Kong, in Australia, New Zealand, North America, and in other parts of the United Kingdom, Wales and Scotland and Northern Ireland. So it's really encouraging to hear of the interest also in Israel. What was clearly evident was to meet the demands placed on mental health, we needed a revolution, not an evolution, in the way mental health was organised and structured. And part of that revolution was the development of a new workforce, the psychological wellbeing practitioner workforce, which I'm hoping by the end of this talk, you'll understand a little bit more about. I've mentioned the Improving Access to Psychological Therapies programme, and this was an English programme, it still is. Huge investment in mental health, over £500 million in the last 10 years. And the real achievement is this investment has been continual under 3 successive different types of government. So we know we're doing something right. We're hitting targets. A central feature of this investment, however, was to develop a new workforce, the psychological wellbeing practitioner. We knew we needed this workforce because the old system of employing clinical psychologists, great workforce, but we could never have employed as many as was needed to meet the demands of people with common mental health problems. We knew we needed this revolution. So, a fundamental characteristic of the Improving Access to Psychological Therapy programme, spearheading this revolution, was the psychological wellbeing practitioner workforce. And why do we need PWPs? Well, I sort of alluded to it earlier. The previous model was we had the biggest workforce in mental health were either psychiatrists or clinical psychologists. But they were specifically and mostly pulled into working with people that met their competencies with severe and enduring mental health problems. But this is the tip of the iceberg, if you like. This is the smallest group of people needing treatment, and we were investing in the biggest workforce, the clinical psychology and the psychiatry. So there was if you want, it was a mismatch, because the biggest demand for mental health is people with common mental health problems. By common mental health problems, I mean high prevalent mental health difficulties such as depression and anxiety disorders, generalized anxiety disorder, panic disorder, simple phobia, these types. So we had a problem here. All the investment in mental health was going to a small number of very expensive mental health professionals who were largely dealing with a very small number of people with more severe and enduring mental health problems, where the demand, the greatest demand for mental health, was coming from the common mental health difficulties, where there wasn't a workforce. And we knew within budgetary constraints, within financial limitations, we needed a big workforce to work with this biggest area of demand. And that was the development of the psychological wellbeing practitioner workforce. And this workforce is based on competencies. Competencies developed to support cognitive behaviour therapy, self-help interventions. Different competencies to high-intensity therapists who deliver therapy, different competencies to clinical psychologists, psychiatrists who work predominantly with a different group. Also, what's characteristic of this workforce is they don't need a professional background. They don't need to come with lots of experience already, as long as they receive the competency-based training. But whilst they don't need a professional background, they are now able to be registered by professional bodies. So, for example, there is a registration process available in this country through the British Psychological Society or through the British Association of Behavioural and Cognitive Psychotherapy. So it's very clear that this workforce is being taken very seriously by professional bodies. The benefits of this way of working is if we get the CBT self-help interventions to deliver the psychological therapy, the CBT, it reduces demands. It reduces demands and costs placed on the service and on society that has to fund the service. And it can also reduce the demands and costs placed on the user, the patient, because the patient is able to use, between support sessions, the materials at a time and a place that's convenient to them. Whilst it reduces the demands placed on the patient and on service, we can increase access to psychological therapy. So waiting times in this country before the Improving Access to Psychological Therapy programme was over 12 months. Now, most services are able to deliver and see people for an assessment within 30 days. Quite a massive reduction. And DWPs, as well as offering support for this range of interventions, also offer support for medication taking. We know the reality is that some people with depression may also be taking antidepressant medication. But it's more likely to be effective if there's also someone, as well as maybe supporting CBT self-help, is supporting the medication taking as well, increasing the chances of therapeutic success. What is the evidence base for low-intensity CBT? Often people say, well, I don't like the sound of this. Well, IAPT, the Improving Access to Psychological Therapy, is based on the evidence, a review of the evidence. And low-intensity CBT is very strongly accepted, recognised, the evidence, through the National Institute for Clinical and Health Excellence in the UK, an independent body that looks at the evidence and makes decisions as to, is this effective for delivery or not? And low-intensity CBT is effective for delivery. Now, step care, people may be, so if this is an alien concept to some different countries that don't have this model for mental health, and indeed we didn't have until about 10 years ago with the improving access to psychological therapies. But what people do understand a lot is if we draw comparisons to how physical healthcare is organised, and most countries have a stepped care physical health system. Therefore, in most cases, if you have a mild to moderate physical health problem, you don't immediately go to the hospital to see a specialist. That would just create blockages. It will create massive waiting times. Mostly people go to the step 2, which is your general practitioner. And your general practitioner will do the assessment. They will identify the appropriate step in the step care model for further investigation or treatment. If they're going to use, and they've done an assessment and they identify a low intensity treatment, maybe medication, antibiotics for a mild to moderate physical health difficulties, they can directly support the delivery of that treatment, and potentially the patient will be treated at step 2, the general practitioner level, only. It's only if that person is identified at assessment as potentially needing further investigation or specialist treatment will they be stepped up. So they may enter step 2, which is time with a consultant who has a higher range of specialist investigative equipment, tests available for them to make decisions, and maybe the consultant, the step 3 therapist practitioner, will be involved. Or they may then say, on the basis of your investigations, you need surgery, a very intensive, invasive intervention. And that would be seen as step 4 or step 5. And that's where the very, very experienced clinical psychologists or psychiatrists would be involved in mental health, equivalent to the surgeons or the very experienced specialists in hospital settings. So step care is a model we've had in physical healthcare for years. We've now implemented it within mental health care, and the PWP role within that is at step 2, sort of equivalent to the general practitioner in physical health care. We've seen over the last 10 years significant success with psychological wellbeing practitioner role. It's been one of the big successes of the Improving Access to Psychological Therapy programme. So we've been around for 10 years. What developments have we seen in the psychological wellbeing practitioner role? Well, something that we've been involved in is developing a step 2 service, a low intensity CBT service for armed forces veterans. People who have been in the armed forces and are leaving or left, and they're experiencing common mental health problems. So we've created a range of adapted step 2 interventions, adapted to their culture. And this has required the use of different imagery, required the use of different engagement techniques, but the interventions are still fundamentally step 2, where it's a common mental health problem with a step 2 evidence base. So the application of step 2 and the psychological wellbeing practitioner role to different populations has grown massively. We've been involved in a study in a regional area of England, in Cornwall, where we're moving into physical health, and the PWP is moving into physical health roles. So, for example, in Cornwall, we trained the PWPs to work with carers of people with dementia. So we developed step 2 interventions, and we trained the PWPs to support the carers who were supporting the low intensity, the CBT self-help intervention for people with dementia who had depression. So it was a very interesting model that PWPs were involved in and at the very forefront of. And what potential is there for promotion as a PWP? Well, we're seeing senior PWP roles now. So these are service leads. They're leading services. They have increased responsibilities. They're no longer just delivering psychological therapy, but they've been trained with continuing professional development training to work in case management roles, offering supervision and clinical skills. So they're becoming very much supervisors of other PWPs in their service to move into hospital healthcare settings where the problem is a step 2, low intensity difficulty. So there's lots of opportunities for the PWP role to make a difference to adult and children and young persons' mental health, but also moving into different areas and specialisms. So if I leave you with a message, it's go make a difference as a psychological wellbeing practitioner. The future, I believe, for psychological wellbeing practitioners and step 2, low intensity CBT, is very bright. The future ahead is bright. It's a positive place to be, and well done for getting into this area of practice. I hope you have a very, very good conference. I hope this has been giving you a bit of a context to understand the role of the psychological wellbeing practitioner. A very, very good conference. And have fun and enjoy yourself. You're going to learn a lot. Thank you for listening.